It's an early morning session, and we are having Dr. Shashank, Dr. Shubroto, and Dr. Hazim. Thank you very much for coming. Our session, we have to start even if there is nobody to listen. First presentation is by myself, management of rock-hard cataracts. Next is phaco in small people. We have Dr. Suven Bhattacharya with us. Dr. Suven Bhattacharya, everybody knows. He is the, inventor of BHEX people expansion device and BHEX forceps. And small people phaco has been made simple, and we are very confident in doing small people phacos nowadays because of his invention, the BHEX. He was with me in Jipmar, Pondicherry, and I was doing diploma in ophthalmology, and he was doing MS, but I was 6 months senior to him, and I'm happy to inform you that I taught him DCT. Okay. Then I have a case of 3 to 4 clock hours of jugular dehiscence, how I managed that case. Then we have Dr. Sugato Paul. Dr. Sugato Paul was he was member scientific committee of OSWB, and he's a very senior surgeon, and he's an excellent teacher. We will learn from him the management of posterior polar cataracts. And then what I designed recently is a pre-chopper to divide the soft nuclei before we go into the anterior chamber with the handpiece. Pre-chopper and sustainer, I have a presentation in that. So with these few words, let me start. It's not coming in the screen. Okay. So to overcome any challenge, we have to be stronger than the challenge. We have to groom ourselves. We have to exercise and be stronger. We have to be more experienced. In rock-hard cataracts, manual small incision cataract surgery is a good option if the surgeon is not competent enough to do phacoemulsification in such cases. It's a very good option. This is a video from Arvind Eye Hospital, Pondicherry. So you'll see, I'll have to just forward this. How can I? Suven, please come here. Forward করার বারটা পাচ্ছি না কেন? Yes. So we have to make a large sclerocorneal tunnel, and then we can safely deliver after a large rhexis. We can safely remove the nucleus, deliver the nucleus through this large wound using whatever technique, either fish hook or irrigating vectis or viscoexpression, whatever. But we should do a very safe surgery in hard cataracts, and so that the corneal endothelium is not damaged. Okay. Next is, this is Mohanta's modified SICS. Here, we make two small incisions side by side, and this wound becomes large, but at the end of the surgery, we will have to put just one suture at the apex of these two wounds. So just SICS, but the wound is like this, two SICS wounds side by side. I sometimes call it double SICS, or in this case, the iris came out and immediately the pupil became small, but still we could manage it. A rigid IOL is placed, and at the end we just put on suture. There is no sagging of the wound, and the astigmatism is taken care of. And now let me tell you about Mohanta's submarine chop. This is meant for cataracts which are hard, which are grade 4 or grade 5. In such cases, we stain the capsule with trypan blue dye and do a large capsulorhexis. Management becomes easy, and nucleus management becomes comfortable if we do a large rhexis. Hydrodissection is done at multiple points, and small amounts of fluid is injected at multiple points. 3 ways to divide such things: divide and conquer technique, direct chop, that is my technique, submarine chop, and crater and chop. Submarine chop is where you don't make any trench. I go with high vacuum and high flow and high power, 70 to 80, 90%, 75 to 90% power, and in continuous mode. But when we bury the tip into the substance of the nucleus, we have to control the power so that the initial engagement, initial embedding into the substance of the nucleus, at that time we deliver very low power so that cavitation bubble doesn't form. After going inside the nucleus, we can apply higher power. This is in this video we are going to observe. This is a video highly edited, and it is about 4 minutes. So this is the almost black cataract, grade 5 nucleus. We may think, is it possible to do such cases without making any trench? Yes, with this technique it is possible. A large capsulorhexis is done. After making the large rhexis, hydrodissection is done at multiple points, and at this time small aliquots of BSS or ringer lactate, whatever you are using, is injected. The nucleus is mobilized. Visco is HPMC. We can use viscoat, and underneath the viscoat we can use HPMC. And now some superficial cortical lens matter is removed, and then we have to go and travel through the substance of this nucleus. As a submarine moves through water, here the tip of the phaco needle will go through the substance of this very hard nucleus. No sculpting is done. The tip is buried just in front of the main wound. It goes through the substance of the nucleus near the opposite equator, and as it reaches near the equator, the chopper is used to get a nice crack. Now 1 or 2 sculpts to go to deeper plane. Hold the right heminucleus with vacuum and the chopper divides the two heminuclei completely. And this heminucleus is being divided into 3 pieces. This is one piece. When we divide the heminucleus, similar technique, the phaco needle goes through the substance of the nucleus and we divide it. And now we tilt each nuclear fragment and emulsify. You can see there is no cavitation bubble formed because we have to control the power by our foot. We have to train the delicate foot muscles so that we deliver appropriate amount of ultrasonic energy at the right time. At this time, since I am using only SPMC, I come out, fill up the anterior chamber with visco, and then again I go with the handpiece. And now this heminucleus is divided into 2 pieces and emulsification is carried on. See, some cavitation bubble formed. Immediately we have to use aspiration and remove those air bubbles. At this time, if we tilt the handpiece and the irrigating ports are directed towards the bubbles gets move and come to the aspiration port. And now, during emulsification of the last 2 nuclear pieces, we have to be extra cautious. At this time, if we lose patience, anything can happen. We can just touch the posterior capsule and all our efforts till now may be lost. So we have to be very careful at this time. If necessary, at this time we come out, inject visco, place the lens under the piece, and over the IOL scaffold, we can remove the last piece. So this is submarine chop, and it may not happen in all cases. When submarine chop fails, we have to make a deep crater at the center, and from there, we have to start chopping. The nucleus is huge, and the phaco needle. In this case, let us forward this to capsular axis is done. And now this is a harder nucleus. And the tip is not going to the proper depth. And as I go near the opposite equator and try to chop this, the chopper just scratches the surface and it cannot crack the nucleus. So I go to scalp mode, make a deep crater at the center so that the tip can be nicely buried into the substance of the nucleus, go to proper depth, and then start chopping. This is crater and chop. And after making several cracks, we start emulsifying the nuclear pieces. Sometimes the leathery posterior bands are there, so it becomes very difficult to separate the pieces. We have to get on free piece and then continue. And once we finish such cases, we become more confident about managing next cases. Thank you very much. And now I invite my friend Dr. Suven Bhattacharjee to enlighten us on small people.